Hi everybody, you are listening to the Medea podcast series. Medea Medical Education Academy is a global medical education provider dedicated to designing, delivering and evaluating medical education programs worldwide. Today we will be speaking with Gabriela Brenta, Chief of the Thyroid Division of the Dr. Cesar Milstein Hospital and Assistant Professor of the Medical School University of Buenos Aires in Argentina. At the end of this podcast, learners should be able to appreciate the complexities of care post-thyroid surgery and the need for personalised and long-term treatment of patients, as well as understanding that maximising quality of life for patients with hypothyroidism is complex. This podcast is part of the continuing medical education programme entitled Hypothyroidism 2026 – Importance of Personalised Treatment, targeting endocrinologists and other healthcare professionals involved in the diagnosis and management of thyroid disorders.
Good morning, and thank you for joining me. I am Dr. Gabriela Brenta from the Cesar Milstein Care Unit in Buenos Aires, Argentina. Today, I'd like to discuss a topic we encounter almost every week in endocrine practice, yet one that remains far more complex than it initially appears: managing patients after thyroid surgery. For many years, postoperative thyroid care was viewed primarily as a replacement problem. Remove the gland, prescribe levothyroxine, normalize TSH, and follow the laboratory values. But increasingly, we recognize that this approach is insufficient for many patients. Post-thyroidectomy management now requires individualized decision-making involving thyroid cancer risk stratification, TSH suppression goals, levothyroxine absorption, formulation selection, long-term surveillance, and patient-centered outcomes. And importantly, this individualized approach has become even more relevant with the recent 2025 ATA thyroid cancer guidelines. These recommendations substantially reframe how we should think about TSH suppression after thyroid cancer surgery. Historically, management was largely pathology-driven. High-risk disease meant aggressive suppression. Intermediate-risk disease meant moderate suppression. And low-risk disease generally targeted the lower reference range. But the newer guidance moves away from rigid TSH targets and instead emphasizes dynamic risk stratification and response to therapy. In other words, the patient's ongoing biochemical and structural response may matter more than the original pathology alone when deciding whether continued TSH suppression is truly necessary. And importantly, the guidelines recognize that the risk of chronic suppression, such as atrial fibrillation or cardiovascular morbidity, bone loss, anxiety, and impaired quality of life, are not trivial, especially in older patients and those with comorbidities. So, today, I'd like to focus on three practical questions. First, why levothyroxine absorption is frequently problematic after surgery, and what we can do about it. Second, which postoperative patients are at greatest risk for impaired long-term outcomes. Third, when should we consider levothyroxine therapy after hemithyroidectomy? And overarching all of this is one key message. Post-thyroidectomy care requires personalized long-term management, not simply hormone replacement. Patients after thyroid surgery are not a homogeneous population. We manage patients after total thyroidectomy for benign disease, patients with differentiated cancer requiring varying degrees of TSH suppression, patients with after lobectomy who may remain euthyroid for years or develop delayed hypothyroidism, patients with autoimmune thyroiditis, patients with obesity, gastrointestinal disease, polypharmacy, or altered absorption. And importantly, the goals of therapy differ substantially. For benign disease, we usually target a normal TSH range. For differentiated thyroid cancer, goals depend on recurrence risk, response to therapy, age, cardiovascular risk, bone health, and comorbidities. The newer ATA framework increasingly emphasizes avoiding unnecessary chronic suppression in low-risk disease because the harms may outweigh the benefits. And perhaps the most important conceptual shift is that suppression decisions are now increasingly driven by dynamic response rather than pathology alone. So, postoperative thyroid management has become substantially more nuanced and individualized.
Can you give us a brief overview of the problem of inadequate gastrointestinal absorption of LT4 and measures you might use to counter it?
Let's begin with a very common but often underestimated issue: inadequate gastrointestinal absorption of levothyroxine. We know that levothyroxine absorption is surprisingly fragile. Under ideal fasting conditions, approximately 60 to 80% of an oral dose is absorbed, primarily in jejunum and ileum. But for absorption to occur efficiently, the tablet must first dissolve in an acidic gastric environment. That means anything interfering with gastric acidity, intestinal integrity, or drug dissolution can significantly impair bioavailability. The most frequent culprits are medications. Calcium carbonate, iron supplements form insoluble complexes with levothyroxine. Bile acid sequestrants, sevelamer, and ion exchange resins bind the drug directly, and proton pump inhibitors are especially important because they reduce gastric acidity and impair tablet dissolution. Many postoperative patients are taking several of these simultaneously. Food interactions also matter. Coffee, soy, fiber, milk, and eating breakfast too soon after ingestion can substantially reduce absorption. Then we have gastrointestinal disorders such as celiac disease, lactose intolerance, Helicobacter pylori gastritis, autoimmune atrophic gastritis, inflammatory bowel disease, and giardiasis. These conditions frequently manifest clinically as unexpectedly high dose requirements. And sometimes the problem is not resistance to therapy. It is simply impaired delivery of the hormone. So, how do we address this? The first step is education. Patients should ideally take levothyroxine on an empty stomach 30 to 60 minutes before breakfast, or alternatively at bedtime several hours after the last meal. And importantly, calcium, iron, multivitamins, and antacids should be separated by at least 4 hours. But in real-life practice, adherence to these timing rules is difficult. Many patients have complex medication schedules, shift work, gastrointestinal disease, or inconsistent eating patterns, and this is where newer formulations become extremely useful. Liquid levothyroxine and soft gel capsules represent a major advance in postoperative thyroid care. These formulations bypass many of the dissolution problems seen with tablets. They are less dependent on gastric acidity and less affected by food or coffee. For postoperative patients with fluctuating TSH, despite apparently good adherence, a structured absorption review is essential before assuming non-compliance.
Which patients are most at risk for poor long-term outcomes after thyroid surgery?
I'd like to discuss this by identifying which postoperative patients deserve particularly close long-term follow-up and proactive management. Importantly, not all postoperative patients experience the same burden. Several high-risk groups consistently emerge in the literature. Perhaps the strongest predictor of persistent postoperative burden is simply the need for levothyroxine therapy itself. Studies consistently show that patients undergoing lobectomy who remain euthyroid often report the best long-term outcomes. In contrast, lobectomy patients who develop hypothyroidism and require levothyroxine frequently report outcomes similar to those undergoing total thyroidectomy. And this is a very important clinical point. The need for hormone replacement may influence long-term well-being more than the extent of surgery itself. And this observation aligns remarkably well with the evolving ATA philosophy, which emphasizes the preservation of endogenous thyroid function whenever safely possible. Then we have patients with surgical complications. Patients that develop hypoparathyroidism, hypocalcemia, vocal cord dysfunction, or persistent hoarseness experience substantially worse postoperative outcomes. These complications affect physical functioning, communication, emotional well-being, and social confidence. Although many improve over time, the early postoperative burden can be very significant. Then we have thyroid cancer patients. Patients with thyroid cancer face unique psychosocial challenges compared with patients operated for benign disease. Even years after surgery, thyroid cancer survivors may experience anxiety about recurrence, uncertainty regarding long-term prognosis, impaired concentration, financial stress, and reduced social well-being. And importantly, recurrence itself is strongly associated with worsening long-term outcomes. This reminds us that survivorship care includes psychological management as well as biochemical surveillance. Then we have patients with comorbidities. Patients with depression, diabetes, obesity, and cardiovascular disease also consistently report poorer postoperative outcomes. Depression, in particular, is important because it overlaps symptomatically with hypothyroidism. Fatigue, cognitive dysfunction, sleep disturbance, and reduced motivation. And if we attribute all persistent symptoms solely to thyroid hormone replacement, we may overlook major contributing factors. Also, female sex and high body mass index are associated with poorer postoperative outcomes. This likely reflects complex interactions involving hormonal physiology, autoimmune disease burden, metabolic factors, body image concerns, and increased rates of anxiety and depression. Obesity additionally complicates levothyroxine dosing and may increase the frequency of dose adjustments. Another important point is timing. The first 3 months after surgery are often the most difficult. This period is coincidental with hormonal instability and recovery from surgery, dose titration, pathology-related anxiety, and adjustments to chronic medication use. Most postoperative hypothyroidism is diagnosed within 3 months or 6 or 12 months. But importantly, hypothyroidism may also develop years later, so long-term surveillance remains essential.
When is levothyroxine replacement to be considered after hemithyroidectomy?
And this question is highly practical. The answer is not automatically. Approximately 23 to 47% of patients eventually require thyroid hormone replacement after lobectomy, meaning that the majority may not. For most patients, observation is the preferred initial strategy. Why? Because postoperative hypothyroidism is frequently transient. Roughly 1/3 of patients develop temporary subclinical hypothyroidism that later resolves spontaneously. If we start therapy too early, many patients may remain on levothyroxine indefinitely, and only a minority successfully discontinue therapy once started. So when I would start therapy, I would strongly consider levothyroxine in several situations. First, overt hypothyroidism, TSH above 10, low free T4. Second, subclinical hypothyroidism with a TSH between 4.5 and 10, especially if you have fatigue, cognitive symptoms, weight gain, or other compatible features. Third, thyroid cancer requiring lower TSH targets. For low-risk differentiated thyroid cancers, we may still aim for amide suppression or low-term TSH values depending on risk and response to therapy. However, the recent ATA 2025 guidelines no longer recommend routine aggressive TSH suppression for many differentiated thyroid cancer patients. Importantly, for lobectomy patients, a TSH below 2 is no longer required to be routinely achieved. The 2025 ATA guidelines note that if the TSH goal is within the normal range for low-risk cancer patients, about 70 to 80% can avoid thyroid hormone supplementation. But if the goal is 0.5 to 2, as it was before, only 20 to 30% of patients with hemithyroidectomy can avoid it. And this is clinically important because avoiding unnecessary thyroid hormone therapy may itself improve long-term outcomes and reduce overtreatment. So, even patients initially classified as higher risk may not require prolonged suppression if they demonstrate an excellent biochemical and structural response over time. Which patients are at higher risk? Several predictors consistently emerge. Preoperative TSH above approximately 2 to 2.5. Hashimoto's thyroiditis. Positive thyroid antibodies. Smaller remnant thyroid volume. Older age. Obesity. Female sex. These patients deserve closer follow-up because delayed hypothyroidism is common. And importantly, hypothyroidism may appear not only within the first months, but years later. So, annual monitoring remains essential.
What take-home messages do we have at the end of this podcast?
To conclude, I would like to leave you with 5 key messages. First, post-thyroidectomy care is far more complex than simple hormone replacement. Second, levothyroxine absorption problems are common and frequently overlooked. Before escalating doses, think about drug interactions, food interference, gastrointestinal disease. Third, the 2025 ATA Thyroid Cancer Framework moves us towards more individualized and less aggressive TSH suppression strategies. Fourth, after hemithyroidectomy, many patients do not require immediate therapy. Observation is often appropriate. And fifth, personalized long-term management is essential. Our goal is not merely biochemical euthyroidism. It is helping patients recover stability, function, and long-term health. Thank you very much.
Thank you for listening to this mid-year podcast. For more information about our continuing medical education programs, please visit our website at midyearacademy.com.